engineering, none of these solutions are going to help us in this regard. They have not proven to be effective. So you have to look maybe to change the surgical protocol rather than to change your graft materials. So let's take a look at something like this. We'll take every possible shortcut that you can possibly take. We're going to use short implants, ultra short implants, Crestal approach, no graft material, satisfy everybody. All you have to do is show up in your office in the morning and the procedure is finished. Nothing difficult. Let's see what happens, okay? There's an example of a case with 1 millimeter of crestal bone, Crestal approach, LPRF, and there's your implant, 6 millimeter implant, okay? So let's look at the study and see how that works. My friend Dr. Testori has done a study in Italy. It's a small study with 74 implants being placed, and it's quite a while ago, using implants that are 6.5 millimeters in length or less. You have to be very careful at case selection. You can't use a distal implant. If it's distal, it must be splinted. It must be two. Single in between two protecting teeth, just to protect the occlusion, because you're dealing with a minimal, restorative unit. These are the implants in the study. They were either 4 or 5 millimeter diameter. The 4 millimeter diameter were 6.5 millimeters in length. If the diameter was 5 millimeters, he used 5 and 6 millimeter implants. These are all not short implants. These are ultra short implants, different category. Above 6.58, that's short implant. This is ultra short. The protocol for the study: Crestal sinus floor elevation with piezo. LPRF is your graft material. It's a two-stage protocol. You're going to do the sinus lift first, leave it closed. 6 months later, come back, place your implant. Okay, wait again. Okay, come back, uncover it, provisional restoration, and then final restoration. 6 month healing, wait, then uncover, 2 months, and then provisional, then 2 months, then permanent. If you have a perforation, and they had 5, the protocol was to place an implant that was 1 millimeter longer than the original crestal bone. So you have a perforation, you put 1 LPRF up. If you have 4 millimeters of crestal bone, you put in a 5. If you have 5 millimeters of crestal bone, you put in a 6. If you have 3 millimeters of crestal bone, you do a lateral window, because there is no 4 millimeter implant, right? So you could either put in 1 millimeter more than your existing crestal bone, or turn it into a lateral window, repair it, and take the patient out of the study. They were able to repair all of them except one using this. Okay, and that's what a perforation looks like through a crestal approach. How do you repair that? It's not really possible. So let's look at a typical case. First molar with that much crestal bone. Piezo to expose the sinus. That's the DASC instrument to release the membrane. Membrane is released, just a little. LPRF. There's your case. You can see where the LPRF is. You see the dome over the top? It's up high. It's like 4 millimeters above the implant, right? You see it? That's the LPRF. You see what happens when it heals. There's the restoration. Do you like the Kremlin-Root ratio? It's not so good, okay? But there's your molar, and look where the bone is, right at the apex. Remember, the LPRF was up here, the implant was here, now it's here. Look back. I can't reach it, it's too high. But there's the LPRF over the top. And here's where it lines up. Here's one of the perforation repairs. LPRF, implant 1 millimeter longer, and that's how they will wind up. Apex of the implant right at the bone level. All right, so here's the results. Implant survival rate was 93.3%. The question is, do you take a procedure that had a 98.6 implant survival rate and make it easier and wind up with 93.3? That's great for all of those patients except the 6% more that failed. And where do you think the failed implants go in a case like this? In the sinus, half the time. So now you have to do a lateral window to take out the implant that went into the sinus, graft it, and finish. So for me, I would not do this in my office. I think I don't want to give up 5-6% because those patients are going to be very unhappy. I would rather do something that has a higher survival rate. If this worked 97% of the time, yeah, maybe, but not 93, okay? You can always ask the patient, you know, well, I have this other procedure and we don't have to do very much of anything. But if it fails, I have to go in here, take out the implant, and do what I would have done at the beginning. Yeah. So I don't know, but I present it to you to show you what minimally invasive can be. Okay? If you use every single thing, minimal surgical protocol, minimal implant left, minimal graft material. There it is, 93.3 by very good surgeons. Okay? When you're doing this, I've seen people do this. When you go to place that 5 millimeter implant, 1 millimeter of bone, right into the sinus. How do you get it? How do you get it off the carrier? Sometimes you lose it right away. Okay? So somebody asks about cysts and polyps. Okay, when are these things a problem? Now, the first thing you have to remember about a mucus retention cyst is its definition. It's called a benign mucus retention cyst. It's benign because it's not a harmful thing. The only problem with them is if they get large, they take up a lot of volume. They form on the floor of the sinus, and when you do a sinus graft, you have to elevate them. So if it's a very large cyst, you elevate it, and then the elevated cyst plus the postoperative inflammatory reaction blocks the ostium. And now you've got a problem of postoperative sinusitis. So how do you prevent this? Well, what we used to do in the past was we sent the patient to an ENT, and he would do functional endoscopic sinus surgery and go in and either remove the cyst or more likely just tear part of it away. So instead of being a cyst, it's just now epithelium lying flat. And the term for that is marsupialization. They just get rid of the cyst cavity and leave the epithelial lining there. And that works, but it's a surgery. And now you're sending the patient to have a fairly uncomfortable surgery, because after they do this, you've got gauze stuffed in your nose, and it's not pleasant. Plus, it may or may not be covered by your insurance. You don't know. For the patient, it's another surgical procedure, and you now have a patient who's accepted an implant, they've accepted a sinus lift, they've accepted a restoration, and now you're sending them to an ENT for endoscopic sinus surgery. Then say, yeah, you know what, make me a partial. You know, it becomes too much. So, do we have a better way to do this? And we do. You know, what does a cyst look like? The way you identify them is they usually are radiopaque. They're usually from the floor of the sinus rather than the walls. And they usually have a domed top because they're filled with fluid. So you get that dome effect, meniscus effect. So the size varies dramatically. And that's what's important to us, the size. Because if it's small, you just lift it up and just make believe it's not there. If it's large, you have to address the problem. So this is what we started doing. We do a complete osteotomy for our window. We take the bone away so we can see inside. And our CT scan will tell us where the cyst is. So we take a needle through the Schneiderian membrane and aspirate the contents. The cyst does not go away. The cyst is still there, but instead of being like this, it's now like this. And a cyst like this is not a problem. Okay, we don't have to worry about that. And you just go ahead and do it. And you can tell the patient, well, you have this cyst. It's not a harmful thing, but it could be a problem if we push it up high and it blocks your sinus, and then you're going to have trouble. So I'm going to drain it rather than send you for another surgery. Now you're a hero, okay? But you also say it could fill up again, okay? And if it does and it becomes a problem later, then you'll go to the ENT doctor. So that now it's not your problem if it fills up again, right? So we do this. Now the question is, if we do this, how often does it work? So let's look at a video of what it would look like to do this. You see the dark shadow at the bottom? That's the blockage of light. We have an endoscope in here now, so you can see from the inside. There's the cyst, it's not a large one, and watch what happens when you're draining it. You see the shadow of where the cyst is. Okay, so the cyst is still there, but now it's not a problem. So I've had these where I think we drained once 8 cc's. This is a big volume from a cyst, and just went ahead and completed the procedure. And there is the case on the other side, you know, before and after. At the same video over here. Let's get out of here. And if you look at the case, on the top, that's the preoperative cyst going across the top. And then down on the bottom, we did simultaneous removal of the cyst, graft, an implant placement. And you see the cyst not there. So now you have to say, is this going to come back? So we have to follow these for a long time and see what happens. Well, a long time. We followed it for 3 years. Okay? And we look at the case and we see at the end of 3 years, we started with 15 patients, 12 of them, there was no regeneration of the cyst, and the 3 where there was, it was only very small. So it's all the cases are then successful. So this is how I would deal with this type of a problem. Okay? It's my first choice is to inform the patient and then reduce the cyst in size by aspiration and go about doing the sinus lift as normal. Okay, what if you perforate a membrane? Okay, so we talked about the Schneiderian membrane being the structure that helps us contain our graft material. We're putting a particular graft material that will be surrounded by bony walls, okay, and in part by the Schneiderian membrane. So if the membrane is torn, we can't contain our graft material. It's going to go through the sinus. It's going to cause inflammation, possibly infection, possibly the particles will block the ostium, and then we'll wind up with a postoperative sinusitis. So we have to contain our particles, and we have to find a reasonable way to repair things. And you have to remember that when you do a repair, you should, in your mind, know that what I did is stable and it's not going to break down as soon as the patient walks out of the office. Because that's now involves 2 surgeries. Now you have to go in and clean it out, and then you have to go back in and regraft it. So you want to make sure that what you're doing is going to be successful. And you can really figure this out, very nicely. For me, repairing it is much better than closing and coming back in a second time. If I repair it, the evidence shows that I will have the same success rate. It doesn't involve any extra surgery. It doesn't change the time that it takes to complete the case. If I decide to close and come back, that's already a time delay. How long do you wait before you go back in? A couple months. Now you go back in, and now your Schneiderian membrane is now joined to your periosteum through the window. You have to do a split thickness flap to gain access to the old window, and now the membrane is adhered all the way around the circumference. It doesn't want to release, and it's going to tear again if you try to work in the same osteotomy. So what you have to do to avoid that is make a new osteotomy slightly larger than the old one, and stay away from the adhesions, and just elevate that combined piece of periosteum Schneiderian membrane up. Now you have soft tissue in your sinus, which is not a good thing. So we put a collagen barrier membrane up to block it off and go ahead and do the elevation. But so much more difficult than repairing it the first time, okay? And you have to look at what the success rate is for doing collagen repairs. And if that's high, then that's the best choice. So we can look at that. In this study by Becker, where he had 200 sinus lifts, he had 40 perforations, which is your 20% for using rotary instrumentation. That's what happens. And of the 41 perforations, he was able to repair all of them except 4. In other words, he could repair 90% of his perforations. And they went on to be all successful. So This is the answer to that. You can repair most perforations, and a successful repair has the same implant survival rate and the same low complication rate as any case where you didn't perforate. So it's very, very easy to figure out what you should do. We talked before about where the perforations are most likely to occur. You remember that was the study we did at NYU that showed that the anterior portion was narrow. That's where we're going to have our perforations. In the middle, it's less. In the back, where it's wide, hardly any. Now, these figures are all based on sinuses that don't have septa. If you have a septum in a different location, your perforation rate may go up. But if you make your windows properly, the way I talked about before, I know that I have an obstacle, and what I want to do is I want to give myself the best access to the obstacle so that I can successfully elevate the membrane. So what I'm going to do is I'm going to make a large window that goes right over the area where the septum is, so I have access, visual sighting, and access with the elevators to both sides of the septum. So that's what that study taught us. And Dr. Testori and I, back in 2008, wrote an article on perforation repairs. And we'll show you a couple of really nice ways to use collagen barrier membranes to fix things. You know, here are a couple, you know, just to show you what we do. In the first one on the left-hand side, I just made a new roof. Now you see I covered the whole top. Even if the hole was very small perforation, the sinus membrane moves. It's like a trampoline when the patient breathes. So I want to make sure that my repair is big enough that it doesn't move out of the way. So I make a whole new roof. Is there anything wrong with that? I've already shown you 2 studies that showed that putting a collagen membrane inside there has no negative effect. Remember the sheep study? So I can put whatever I want up there. I just want to make it so that it's stable, that it doesn't move after I place it. The one in the middle, I have a membrane. Part of it is inside, part of it is outside. That's a special case. I'll show you about that. There's a case with 2 perforations where we used PRF membranes to fix it. So we have different ways, you know, to do it. Now let's look at this case. It's a small perforation up against on the superior aspect, right up against the lateral wall. Now, that one was very small, so when I finished the elevation, the tension is off the membrane, and it just closes by itself. You don't have to do anything. But I want to show you what you do with one, so we just put one in with Photoshop. So I put in a perforation near the superior wall. On the superior aspect near the lateral wall. That's a difficult place to do a membrane repair because you put the membrane inside, and as you're placing your graft material, it moves because the membrane moves up. The Schneiderian membrane moves up, and the hole is there again, and you're pulling the membrane out. You put more graft material in, it moves. You can't keep it there. So that's what we did with this. I leave part of it outside, and I fold it in. And now I graft it when it's like that, and it can't go anywhere. The outside piece keeps it from moving. Okay? So that will not open. And then collagen barrier membrane again over the graft like we do all the time. Okay? So that's a special case when you're near the lateral wall. Here's another case where we have to do crazy things in order to keep our membrane in position. First, we have to complete the elevation, get us up so that you're looking at the medial wall there, the membrane is up. And we kind of did a similar thing here. We figured out what we needed inside to cover the perforation, but we folded a piece outside so that the whole thing doesn't move in. And I can do it again for the distal. Part in, part out. Place the graft. You see the membrane outside there holding everything in place. And here's another use of that internal membrane instead of an external one. Suture it closed, and you see all your graft material is contained. Okay, with a very good graft that goes from lateral wall to medial wall, no problems. Here are some other situations. Here where we've used tacks on the outside to hold it in, to hold it up. You notice how the repair goes all the way across to the medial wall. It should actually go further than that. It should drape down on the medial wall, because as you place your graft material, even if your don't graft push upwards, that membrane is going to go like this. I'll prove it to you. It's going to tent up. And if it tents up, it won't reach the medial wall anymore. See, here it's long enough to reach the wall, but if it goes up, it's not long enough anymore. So put a piece in that comes down a little bit. If it moves up, it unfolds, and it still touches. Here's one in the middle where I used sutures because the perforation was so large, I had nothing to rest the repair membrane on. Down below, another tacking situation, and on the very end over there, something called the Loma Linda pouch for very large perforations. Let's look at them. This is the kind of case where you don't get small perforation. What you get is a tear. It just completely opens up. And you have to find a way to restore it. When you look inside here, you're looking inside, you don't see your Schneiderian membrane, you see the patient's brain. Okay, there's no membrane left to place your repair. So what I did is I drilled 3 holes in the bone above the sinus window. The torn Schneiderian membrane is elevated off the floor, it's hanging down on the medial side. I took the suture, grabbed the torn membrane, and tied 3 times. 1, 2, 3. Don't try to close it because it will tear. I'm putting in like a strut, a beam, so that I can rest the collagen membrane on it. So I have the struts in place. I rest the membrane on it. I tack it on the outside so that it doesn't move in. Now, I want to prove something to you. The tacks are above the window, correct? They're higher than my window. Now I'm going to graft it and take a radiograph. Do you see the tacks? Where's the graft? It's higher than the tacks. That's because that whole membrane complex is a trampoline. Patient breathes, it goes up, okay? And now your graft material is up. It had to be long enough to accommodate that. That's why it drapes down the medial wall. But that's completely contained. Look, there it is at 9 months. This one on this side, perfectly contained. Was it a good graft? Yes, it went all the way across from lateral to medial. So it's a perfect graft for placing my implants. Now the only thing I don't know is I don't know if there's any bone, okay? So remember I keep talking about the Schneiderian membrane not being important. So here we had no Schneiderian membrane, right? It was all gone. If the Schneiderian membrane was important, this would all be dead bone graft material, okay? But if we go look, when I put the implants in, you see the dark spot. I took a bone core to see what I had. Here's the case over 20 years later. And here's the histology. 31% vital bone by volume. That's much higher than the average that you get in cases, which is usually about 20%. So here, with no Schneiderian membrane, 31% vital bone. Is the Schneiderian membrane important for bone? No. Said it many times. It's important for containing graft material. And that's what this case shows. Now, perforations get larger than that. Okay? Here's one, another case with a very thin membrane. Again, these are the ones that tear. Now, this perforation on the left side doesn't look that big, but that sinus goes all the way to the midline. It just goes all the way to the midline. And we took this big 40 by 60 collagen barrier membrane, you stick it here's your window, here's your big membrane. Loma Linda pouch technique from California. Now you put in your graft material. But what was happening, that perforation was so big, this thing kept falling in. So we had to put 2 packs to keep it from falling inside.
Loma Linda.
Graft material, membrane on the outside. Close it. Here it is 6 months later, perfectly contained. Here's different histology, but here we had 23%, I think, vital bone. The vital bone is purple here. Okay. Here are the abutments in place. There's the case restored. Okay, so does it work? Yes, it does. And what this study, we had 20 cases like this, all these large perforations. All of them, we looked at them 3 different ways. We looked histology, radiographs, and clinical success. Any way that you could judge the outcome. And all of these cases were 100% implant survival. The only postoperative complication we had, take a guess what postoperative complication you would have with this. Nosebleed, because the membranes were torn. So there'll be a little bleeding, it gets in the sinus, and it comes out. Other than that, nothing. And they all work very well, all using collagen barrier membranes. Now, the question that you should ask, with this case here, that membrane on the inside, this membrane on the outside. How do you get bone when your graft material is completely surrounded by collagen barrier membranes everywhere, 360 degrees? The question is, how do you get bone? And when somebody asks me that, I answer, I don't know. But I have the histology, and I got bone, okay? Which means that the only way that could happen is if at some point the vascular supply got to that graft material. Maybe it was delayed while the membrane broke down, but by that time the graft material had kind of coagulated and stayed in place, and it worked. So I'm very happy to have that kind of solution to very, very extensive perforations. Are we supposed to have a tea break at some point? Now? No? Okay. We could take a couple more questions maybe right now? Later? Okay. The government has forced us now to take a tea break. So we come back in 1/2 hour. Okay. Enjoy your tea break.
Dạ xin mời quý bác sĩ mình cùng giải lao ạ. Rất tiện là quý bác sĩ.
So now I know I'm in a communist